Good afternoon, everyone. Thank you for a very kind introduction. My name is Wei Chong. I'm from the National Cancer Centre, Singapore, and I thank the organizers for very kindly inviting me to this conference. It's my first time in Bangladesh. Today, my talk will be titled Tailoring Non-Surgical Management in Germ Cell Tumor Based on Risk Stratification. This is me, and these are my disclosures. So germ cell tumors are something that occurs in young male patients, and I guess because of this, risk stratification is one of the key things that we do when we see any patient with germ cell tumor. These are the statistics from my part of the world, Singapore, and we can see that in young males, basically testicular cancer, a majority of which are germ cells, actually predominate in the incidence of cancers in young males. It's probably second only to lymphoid neoplasms. And often I say when I'm asked to give a talk on germ cell tumors, I feel a little bit like a fish out of water, and this is why when we look at the global incidence of testicular germ cell tumors, in this part of the world, Asia, our incidence is actually a lot lower than the Western world, and we're looking at, in Scandinavian countries, incidence of up to 10 age standardized incidence rates per 100,000, whereas in Singapore, we're looking at something like 1%, and this is consistent with the rest of Asia. Now, nevertheless, because the stakes are high, it's a curative cancer, we have young patients, it's just always important for us to know about it. And in here, the role of risk stratification cannot be undermined, because risk stratification allows us, firstly, not to undertreat patients, but also, very importantly, not to overtreat patients, because these patients are young, they have normal life expectancy after they are cured, and they are at risk of long-term toxicities. So staging is largely based on AJCC guidelines. So generally speaking, patients with stage 1S, meaning post-surgery, tumor markers do not normalize, but there's no macroscopic evidence of metastatic disease. They're generally treated as advanced disease, just as we treat the 2Cs, 3As, 3Bs, and 3Cs. Now, it should be noted that treatment decisions should not be based on just mildly elevated tumor markers, where AFP of less than 20 nanograms per milliliter, or beta-HCG of less than 20 international units per liter. With that, I go straight into adjuvant treatment. So this is the first aspect of that we often deal with when we have a patient with germ cell tumors. And so this is what the NCCN guidelines say. Basically, we deal with seminomas first. Seminomas, as defined by histology, pure seminoma, so any non-seminomatous components in testicular cancers are usually treated as an NSGCT. In NCCN guidelines, we note that active surveillance for stage 1 seminomas is by and large the strongly preferred option. This is as opposed to the established adjuvant treatment regimes like carboplatin, 1 or 2 cycles, or adjuvant radiotherapy. Now, why is that? So we ask ourselves, is there a role for risk-adapted strategy in stage 1 seminomas? This is the pool analysis published by Ward et al. In JCO in 2002. 638 patients pooled from 4 surveillance studies. In this study, the aggregated 5-year relapse-free survival was about 82.3%, and it was found in this study that the prognostic factors for relapse include tumor size of more than 4 cm and rotate testis involvement. On the right, we can clearly see that the survival curves diverge based on the number of risk factors present. With no risk factors, we are pretty much looking at a relapse risk of about 5 to 10% over the next 10 years, and this steadily worsens with more risk factors. With 1 risk factor, we are looking at a relapse risk of maybe about 20 to 25%, and with 2 risk factors, probably about 30 to 40%. To answer this question, I think the Spanish actually conducted a couple of studies, aptly named the second and the third study. This is by the Spanish Germ Cell Cancer Cooperative Group, and these were based on the risk factors from the Ward pooled analysis we showed just now. Now, one thing to note was that these are non-randomized studies, so all these patients are conformed to a single treatment approach in the study. All patients defined at increased risk receive chemotherapy with 2 cycles of carboplatin. all patients at low risk were put on active surveillance. So essentially, the difference between the two studies, the second study defined high risk as 1 to 2 risk factors, so any one risk factor present portends high risk, whereas the third study looked at a high risk cohort of those with just 2 risk factors and put them on adjuvant carboplatin. While adjuvant carboplatin convincingly reduced the risk of relapse in these studies, it is worth noting that the 3 and the 5-year relapse-free survivals in both these studies were 100%. So the approach didn't actually make a difference to overall survival at all. And chief among the reasons was probably because these cancers were highly salvageable with an aim to cure even in the relapse setting. So, the prognostic model is not very well validated, and this was actually brought up in an editorial by Chong and by, ironically, by Ward himself actually in JNCI of 2011. In particular, the prognostic factor of rete testis has not been easily reproducible in further studies after it was published in the Ward analysis. And so overall, there's no strong evidence for adopting a risk-adapted strategy. That's why NCCN still states the preferred standard of care is still active surveillance in seminoma. An adjuvant approach is, we usually base it on the likelihood of patients to adhere strictly to active surveillance regimes. Adjuvant therapy is still very reasonable in patients whom you think may be at high risk of not complying to a strict regimen of active surveillance and follow-up. Now, what about non-seminomas? So we can see that stage 1 non-seminomas without any risk factors, surveillance is still by and large preferred in NCCN guidelines. However, in those with risk factors, NCCN takes a different approach. They state that both active surveillance as well as adjuvant chemotherapy and nerve-sparing retroperitoneal lymph node dissection are all equivalent treatment options to be discussed with the patient. Why is this? We look at a synoptical study by Tan State et al. In JCO in 2009, 745 patients. This is a Scandinavian study conducted in Sweden and Norway. All clinical stage 1 NSGCTs, all post-orchidectomy. Biopsy of contralateral testes was recommended but not mandatory. And the stage 1 disease was confirmed 6 to 8 weeks post-orchidectomy with systemic staging scans, namely a CT, thorax abdo-pelvis, as well as tumor markers. This is a non-randomized study again. These germ cell tumors were further divided into those with lymphovascular invasion present and lymphovascular invasion absent. Those with lymphovascular invasion present were offered either BEP 1 or 2 cycles according to patient's choice. Those with LVI or lymphovascular invasion negative were offered either surveillance or the option of a adjuvant BEP cycle 1 cycle according to patient's choice. When we look at the results of the synoptical study, with a median follow-up of about 5 years, 8 patients have died, none due to disease. So the disease-specific survival is still holds up. Now, 1 patient died after salvage chemo from a stroke, and overall cause-specific survival is 99.9%. Now, when we look at the curves, the prognostic value of lymphovascular invasion becomes immediately apparent. When we look at the LVI positive subgroup, we note that the relapse risk is almost 40 to 50%, and that's really high. Now, does it actually impact on overall survival? The synoptical study obviously doesn't show that, but why is it that NCCN actually lists adjuvant BEP as an equivalent option to something like active surveillance? And this is my take on it. Synoptical study actually showed that with the institution of adjuvant BEP 1 cycle, this approach for patients with the risk factor of lymphovascular invasion actually managed to reduce the treatment intensity needed for this cohort. And this is key because for patients with LVI positive, just giving them 1 cycle of BEP, the risk-benefit ratio actually swings very much in favor of adjuvant because bearing in mind that once these patients recur, they are treated as advanced disease and they will get 3 to 4 cycles of the same chemo regimen. So this is one of the reasons why adjuvant chemotherapy is advocated for patients with risk factors for non-seminomas. We go on to advanced germ cell tumors, which probably is the one that constitutes most of my work as a medical oncologist. The prognostic, or the risk stratification categories were put forth by the IGCCCG back about more than 10 years ago. And even in, there was a more contemporary publication in JCO in 2021, actually further validating the prognostic value of this IGCCCG risk stratification model today. So generally, our practice is in good risk patients or favorable risk patients, we go with BEP or bleomycin etoposide cisplatin for 3 cycles with an alternative of etoposide cisplatin for 4 cycles, especially in patients who cannot take bleomycin. For intermediate to poor risk patients, our standards of care are usually BEP for 4 cycles or an alternative of VIP with etoposide, ifosfamide, and cisplatin for 4 cycles. So moving on to the good risk advanced germ cells, this approach of de-escalated therapy was validated by a couple of studies, the EORTC MRC published by DeWitt in JCO 2021, as well as by the Indiana group, Einhorn in JCO 1989, and it showed that basically 3 cycles of BEP had similar long-term cure rates as 4 cycles of BEP, and thus it became standard of care for good or favorable risk. Furthermore, the GTAC T93BP study by Kulin et al. In Annals of Oncology 2007 showed that EP for 4 cycles was non-inferior to BEP for 3 cycles, similar 5-year event-free survival, similar 5-year overall survival, but increased toxicities with BEP. So EP was a more well-tolerated regimen. However, it is also worth noting that this trial was underpowered for overall survival, and therefore there is generally a preference towards 3 cycles of BEP for these patients if it is deemed that they are fit for it. For intermediate to poor risk, there are limited studies in this subset. There's no evidence for de-escalation of therapy. Therefore, the standard of care is still BEP for 4 cycles. VIP is an alternative standard of care, and this was shown in the intergroup trial with BEP versus VIP for 4 cycles. The long-term progression-free survival and overall survival were not significantly different in poor risk patients, with higher rates of grade 3 hematologic and genital urinary toxicities with VIP. What about suboptimal response? Is there a role to escalate therapy? In the GTAC 13 trial, 263 poor risk patients, unfavorable tumor marker decline. They escalated the regimen to include paclitaxel as well as oxaliplatin and subsequently BIP for further 2 cycles. No differences no statistically significant differences in disease-free survival. Now, quickly moving on to relapse refractory germ cells, basically defining categories of relapse is important. Those who are chemotherapy naive, we treat basically like a first-line germ cell. Post-adjuvant therapy, oftentimes there's still room to give proper treatment for advanced disease. Post-first-line therapy, we define by categories: absolute platinum refractory, non-platinum refractory, and we may tailor our treatment recommendations for these categories, as well as post-salvage therapy. Is there benefit of intensifying treatments? This is a review by McHugh et al. In Advances in Urology 2018, and we can see that firstly, there's a lot of heterogeneity in the inclusion criteria in the trials. There's only one phase 3 study by Pico et al., which incorporated one dose of high-dose chemotherapy following a couple of doses of salvage regimen. This trial was actually negative, so this trial suggested that there may not always be a role for high-dose chemotherapy followed by autologous transplant in this group of patients. Notably, in this trial, platinum refractory disease was excluded. Is there a role for selection based on prognosis? We have got various prognostic scores, and there's an upcoming TIGER trial, which is the phase 3 randomized study, which investigates the role of just a salvage approach versus high-dose chemotherapy followed by transplant, and we await the results of this study. Take-home messages: risk stratification is key in the management for germ cell tumors, both in adjuvant, advanced, as well as relapse with recurrent setting. Benefit for treatment intensification in patients with suboptimal response in first-line advanced setting is unclear, and for me, personally, is not routinely practiced. And patient selection for salvage high-dose chemotherapy is also unclear at this point, and we await the results of the TIGER trial. Thank you very much for having me.